we're very grateful to have you with us, Dr. Fessler. So
Happy to be here with you all.
I'm going to go ahead and stop sharing my screen here. And yeah, Jennifer and Jaib, you guys are ready to get started.
Hello, thank you so much for the introduction. It's awesome to have you here, Dr. Fessler. So hello, my name is Jennifer. I'm a fourth year medical student and a previous spine research fellow at the University of Buffalo, as well as the Rothman Orthopedics Institute. This is my partner.
I'm Shoaib Ahmed, and I'm a third year medical student from Dhaka University.
We'll be presenting the percutaneous transforaminal endoscopic discectomy compared with microendoscopic discectomy for lumbar disc herniation, a 1-year results of a randomized controlled clinical trial published in JNS Spine in 2018. So just a little bit of the background. According to this article, the result of the spine patient outcomes research trial in 2006, it suggested that there was a greater reduction in pain improvement, improvement in function, and higher treatment satisfaction in those who were managed surgically versus non-operatively. The gold standard for treatment of lumbar disc herniation is microdiscectomy, and this can be done in a minimally invasive manner due to the rapidly growth in minimally invasive spine surgery over the past few years. The two popular techniques have come about, the percutaneous transforaminal endoscopic discectomy or the microendoscopic discectomy.
So there is actually no class 1 evidence suggesting that PTED or percutaneous transforaminal endoscopy discectomy is superior than microendoscopic discectomy in regard to pain relief and functional improvement in lumbar disc herniation. So therefore, 2 randomized control trial, or at least 1 randomized control trial, is warranted. So we have the research question: does percutaneous transforaminal endoscopic discectomy results in better clinical outcomes and less surgical trauma than microendoscopic discectomy? Next slide. Yeah, so we have the study type on randomized single center open label randomized control trial of 153 patients, and 80 participated in PTED and 73 in MED. Of these, the follow-up rate was 89.5%. So the potential participants were patients who had radicular pain and signs of radiculopathy. In addition, patients must have an MRI and CT scan showing the lumbar disc herniation with patients' radicular signs and symptoms. So out of these patients, we excluded patients who are less than 18 years and greater than 65 years of age, Cauda-Equina syndrome, progressive and neurological deficit, urgent surgical intervention, lumbar disc herniation, and those who are pregnant and comorbid conditions and contraindicating surgery. So here is the flow diagram showing the patient's enrollment, treatment, assignment, and follow-up. The next. The outcome assessment, the patients were assessed preoperatively and 1 week, 1 month, 3 months, 6 months, and 1 year post-op. A research assistant collected baseline and follow-up data by administrating questionnaires via telephone, email, mail, or in person. So the primary outcome was ODI, the Oswestry Disability Index, ranging from 0 to 100, with 100 scores indicating more disability to pain. And the secondary outcomes included 36 item short-term survey, which includes pain and physical function, and visual analog cycle, which includes back score and leg score. In each cases, lumbar disc herniation was classified by median, paramedian, and far lateral types, or depending on the location of herniation in different cases. So here is the MR images obtained on a 50-year-old woman with a radiculopathy on the right side. Pre-op MR images shows a lumbar 4-5 disc herniation. Next slide.
So the results of, oh, sorry, go ahead.
Yes.
No,
the baseline clinical characteristics and demographics. The mean age here is 43.4 years, predominantly in male, 58.2%. And the most common type of disc herniation is paramedian, which is 68%. And the most common levels are lumbar 4 to 5 and lumbar 5 to sacrum 1. So next.
Okay, so the results of this study demonstrated that surgically, between the two approaches, there was no statistical difference between groups within the Austrian Disability Index, VAS leg and back, as well as SF-36 in regards to physical function as well as back pain. However, it did demonstrate that both approaches did have statistically significant improvements from their baseline values. So based on stratification, so they looked at their primary outcome, which was the ODI, and they split it up between different types of herniations, between the median type, the paramedian type, and the far lateral type. And this found that the percutaneous approach had significantly greater improvement in ODI for the paramedian compared to the median type herniations in all time points except at the 1 month range. Then they found that MED had greater improvements on paramedian compared to far lateral types after 3 months. For the lateral disc herniation, the MED group had significantly less improvement for ODI score compared to the paramedian type. And regarding central disc herniation, there was less improvement in the ODI score without significant difference compared to the PED group. So basically this demonstrated that the PED group did, I think, better in the median type compared greater improvements in ODI for the paramedian type. So, oops, sorry. And then secondary aims, they also looked at the duration of surgery, and they found that the duration was about the same. PED did have a shorter postoperative in bed time, so patients got out of bed quicker. Their length of stay was 1.4 times shorter as well. The PED group did have a higher surgical cost as well as total hospital cost. So complications and reoperations, the total complications was the same between groups, as well as the reoperation rates were comparable between groups.
Yeah. This study has certain limitations, such as relative shorter duration of follow-up, so long-term results of these two procedures are unclear. And another is the treatment could not be masked by the patients. So past 4 patients, knowledge of the treatment assignment may have had an effect on the patient's outcomes. And both the treatment has relatively small sizes for the subgroup of lateral herniation. Next, please. So the conclusion is PTE did not show superior clinical outcomes and was not safer compared with the MED. And the PTED has inferior results for the median disc herniation, and MED did not seem to be a best treatment, even though the PTED group had the advantage of shorter post-op, the bedtime and length of the hospital stay. However, the surgical and hospital costs were on the higher side. Yes. Thank you.
Thank you.
Thank you.
All right, so how do you like to proceed from here? I'm not muted, am I? No.
No, I think I might have cut you off, but floor is all yours.
Okay, so Jennifer and Shaib, tell me about the experience at your institutions with both minimally invasive discectomy, MED, and percutaneous transforaminal endoscopic discectomy.
That might be challenging for me because I don't have a home institution. At Buffalo, I know they do some minimally invasive procedures, but not a lot. So I would say 0 on that one. At Rothman, I know there's a surgeon that does minimally invasive only procedures. I don't know their clinical expertise on it though.
Okay.
For me, actually, I'm for third year in Dhaka University. In that one, I have seen that the surgeon usually prefer more PTED than MED because it's less post. I mean, it is less invasive and it takes less time on the bedtime, especially on the patients on Bangladesh. The people cannot afford for a longer stay in the duration in the hospital. So surgeon usually prefer PTED. And whereas right now I'm in Qatar, and Qatar has seen in Hamad Hospital in both PTED and MED cases. And even here, most of the doctors prefer a PTED because it's more invasive, less invasive, and the patients, they are, I mean, that's it. Like PTED, most of the doctors usually prefer PTED, and because they're more invasive, less invasive. Sorry.
Great. Now, how about our host? What's your experience in your institution?
Yeah, mine is super limited because I'm still sort of preclinical in my PhD years. I haven't had the chance to see really either of these. I know, so Rutgers is composed of two institutions, or technically three. So Robert Wood Johnson, which is in New Brunswick, New Jersey, and then University Hospital Newark. I know in Newark they do a combination of these, of the PTED and the MED, and that's where our spine surgeon extraordinaire is sort of based out of. Mostly what I've seen spine surgery wise in New Brunswick has been just typical, lumbar discectomies and fusions, not much in terms of the microdiscectomy side.
Okay, so I found this to be a very interesting paper. There are a lot of papers that are sort of like this that are evaluating lumbar discectomy, and then it used to be minimally invasive versus microdiscectomy, and now it's minimally invasive versus PTED. I do both procedures, and I think they said a lot of things that are quite accurate in this manuscript. For a far lateral disc herniation, the percutaneous transendoscopic is really nice. You come right down on the disc herniation, you've got good visualization, you can usually see the nerve root very well, and you can get out the offending disc herniation in the lateral recess very well. It's much harder to get centrally, so even the paramedian and certainly the median are very hard to get at, because at that point you're almost doing it blind because you're trying to work under the dura, you're not seeing it well, and you're kind of probing around in a blind space with limited access. So the results in the paramedian and the median tend not to be as good as the far lateral disc herniation when you're coming extraforaminally. Interestingly enough, there's a couple other things that need to be recognized here. To do a far lateral discectomy through either a microendoscopic technique or a microscopic technique is a relatively challenging operation, and it requires a good deal of experience. And in fact, we're just writing up a new technique now for far lateral disc herniations using the minimally invasive technique, which makes it much, much easier than the traditional approach that we used to take. And right now, it's literally a 45-minute operation. But I think this is an interesting paper. It really shows, especially for the far lateral disc herniation, equivalent results. There were a couple of things that are interesting, though. So this is a Far Eastern publication. And if you look at their hospital stays for the PTED, it was relatively long, 32 hours for hospital stay, plus or minus 4 days. For the MED group, it was 70 hours, plus or minus 3.8 days. In the United States, for the PTED, the hospital stay is probably 3 hours. And for the MED, it's probably 6 hours. So there's an extreme difference in how these patients are treated post-operatively. The other thing to notice was that they nicely said that probably the MED is better for central disc herniations. I think it certainly is. And I think the results of the PTED and the MED are relatively equivalent for the far lateral, but I think there certainly is less trauma doing the PTED. The other thing to consider is the cost. The PTED is significantly more expensive than just getting a tube and doing a minimally invasive discectomy. In the long run, I think they do almost equivalently well. So If cost is an issue, then you're probably going to go with a tubular approach. If not, and if you're skilled, and I think the Chinese, the Japanese tend to be much better at the PTED than most Americans. So I think they're doing a great job. And Rolf Wolf in Germany I've watched do many of these, and he is a spectacular surgeon and can really do some amazing things that I think most of us probably aren't capable of doing. Do you have any questions I can answer?
One of the things that I thought was interesting was they interpreted the sport trial as better for microdiscectomy, but I thought the result of that trial said that there was no difference at 2 years and at each time point. So I was wondering how that was.
Which data you look at. If you look as randomized, then the data wasn't any different.
Yeah.
That includes all the crossover patients who went from
Gotcha.
the one procedure to the other. When you compared the as treated, then the results were significantly better for the microendoscopic discectomy. So they weren't doing MED versus microendoscopic. They were doing surgery versus non-surgery.
Gotcha. Okay.
The surgery group, when you analyzed as treated, was significantly better for the surgery than non-surgery.
Okay. All right. Yeah, that was one of the things I thought was interesting.
And when you think of it, the as treated versus as randomized was a design that was created for pharmaceutical studies, so that there wasn't a whole lot of difference if you crossed over. In surgery, it makes no sense whatsoever to include a patient who's had surgery in the non-surgery group. I mean, it's just nonsensical.
Yes, okay, that makes sense. Yeah.
All right.
We can also open up to maybe a question or two from the general audience if they want to use the Q&A function or the chat. I also had sort of a more general question, sort of related to the as treated versus as randomized analyses. So looking at like the field of oncology where adaptive design is becoming really prominent, do you think there will be any kind of role of that for more surgical trials in spine surgery or other aspects?
I think there probably will. It's demonstrating itself to be of great value in surgical oncology, especially. And I don't see any reason why it wouldn't in routine degenerative disease. And it's a neat advance in statistical analysis, actually.
Yeah, definitely. And the saving on costs of being able to kind of categorize things under this umbrella of a platform is really nice. It looks like we do have one question from one of the attendees. In your experience, Dr. Fessler, has there been any differences in gender or age with regards to patient outcomes in the PTED versus MED?
No, none whatsoever.
Awesome.
When you do the far lateral discectomy, do you do them prone or do you do them lateral?
I do them prone.
Like, are they... Okay.
And I think you can do it either way. And that's just what I've become comfortable doing. And my operating room is comfortable setting up for that and working through all of the procedures you have to do a surgical technique. And I find it very comfortable to do it that way.
Makes sense.
Great. Well, thank you, Jennifer and Shaib. So we can have Belina, if you're ready to share your screen and present the next case.
Hello, yes, I can definitely do that. Oh, it says I cannot start. Let's see.
Make sure you are also a host.
Can you hear me?
Yes,
Yes.
I can hear you.
I have it now. Yes.
Belina, you should be able to share your screen now.
Yeah. I have the button, but I cannot, I don't think I can do that.
Oh, sorry. I think Jennifer, if you can just stop sharing your screen and then we'll
Yeah.
over. Zoom.
Can you do it now?
Yeah, I think so. Yeah. I'm sorry, 1 second. I'm sorry, I think there might be something in my settings that does not allow this on my computer. So I have to go and check that.
If you want to email it to me, I could pull it up.
Yeah, I'm happy to do that. You want to share an email address?
Yes, I'm gonna put it in the chat.
Great, thank you. Yeah, I don't know why this worked just fine last time.
Okay, I just sent it.
Yep, I got it.
Yeah, it's weird. I don't know if you have a Mac, but I know sometimes when it updates, you have to re-allow in the system preferences to basically do screen recording. So it might be that issue. If you want to check that after.
I know it worked last time, but anyways, this will be easiest. Thank you for your patience. I'm sorry about that.
Yeah, and a shout out to you, Valina, for stepping in and doing the presentation by yourself in the absence of a partner. So we really appreciate it.
It was fun. I actually, I'm currently on a neurosurgical rotation and I've been seeing these procedures quite a bit, so.
Well, maybe in the meantime, Dr. Fessler, just as kind of general interest, what kind of work were you doing when you were working on postdoc research in neurosurgery and psychiatry?
So I had just finished my PhD, and for my PhD, I had been working in what at that time was called pharmacology and physiology. That's because they didn't have neuroscience departments yet, but today it would be called neuroscience. My PhD dissertation was defining the pathway from the midbrain raphe to the median eminence, which is a serotonergic pathway. And that synapse is on the dopaminergic pathway, which goes into the hypophysis to control the regulation of prolactin secretion. So that was I defined that pathway. That was my dissertation. And that was done between a person in psychiatry and a person in pharmacology and physiology, which is why I was in both departments. In neurosurgery at that time, what I was working on was studying the impact of complete heparinization on hemorrhage rates following craniotomies. And we were working in dogs at that time. And then we were doing a program of deep brain stimulation for controlling appetite in chronic morbid obesity. And we did that in dogs, and then we did a series of patients. So actually, I was the first person in the United States to actually do human deep brain stimulation for morbid obesity.
That's awesome. Pioneering of stereotactic and functional there.
Yeah, that's where I started. That was long before I became a spine surgeon. Hi, Valina.
Hello there. My apologies for everything, for the scrubs and for the computer not working. Jennifer, did you get my?
Yes, I'm pulling it up right now. 1 second. Okay. All right, so bear with me. I don't quite know how to use this software.
All right. So this study, I will just read the title and then explain what it did and what their aim is. So comparison of clinical outcomes following minimally invasive or lumbar endoscopic unilateral laminotomy for bilateral decompression, and we'll break it down in a second. So lumbar stenosis is narrowing. Next slide, please. Lumbar stenosis is the narrowing of a canal or a foramen, typically caused by a degenerative process, which increases in prevalence with increasing age. There are different places of stenosis. So we can have central stenosis or foraminal stenosis. These are self-explanatory. But then there's also a lateral stenosis, paralateral, paracentral. And some of these we can see on the screen. You don't see my printer, I guess. Okay. So you can see them on the picture on the right. So these stenosis, central and foraminal, in all of these stenosis can cause compression of either the spinal cord or the level of the caudal pinna, or exiting or traversing nerve roots, and they can have radiculopathy, myelopathy, and more frequently the cause different things that are like it can cause severe injury. What causes this stenosis is degenerative, more frequently degenerative disc disease, so degenerative processes, degenerative disc disease, because hypertrophy, ligamental fluid and hypertrophy, or osteoarthritis, which are along the vertebral bodies. The traditional, so open laminectomy without instrumentation or with instrumentation is the recommended in traditional surgical management of spinal stenosis. However, studies have shown that about a third of patients who undergo open laminectomy require revision within 4 years, and post-laminectomy, occurs in up to 5%, 5.5% of patients undergo open laminectomy. Because over the past couple of decades, minimally invasive techniques have been developed and become relatively popular, and they decrease, in general, they decrease a lot of these negative effects of open laminectomy, but they also, another benefit of minimally invasive technique is that they have working panels. They don't require reduction of the back muscles, and so the working panels is through the back muscle, and that decreases back muscle pain after surgery, also due to the reduction of the spinal cord.
Wait, I didn't want to cut you off, but it's coming in, I think, a little muffled. I don't know if anybody else is hearing
Yeah,
it.
it's relatively hard to understand.
I don't know if you might have your microphone.
Do you have trouble hearing me or understanding me?
Here it sounds like a very echoey, muffled sound.
Yeah, it's coming in and out for me.
Yeah, I noticed the same thing.
I'm not
It's
sure.
the same for me.
I'm on my Wi-Fi. I have full reception. Is this better? Am I?
Yes, it's better right now.
Is my voice? Yeah, it's probably my voice. Okay. Is this better?
It is.
Okay, I have a relatively soft voice. Okay, so the two commonly, well, I guess they're not as common. What I've learned today is that endoscopic approach is more common in Asia, but there are two minimally invasive approaches to laminectomy. And one utilizes tubular dilators, and the other one is an endoscopic approach, which is a unilateral laminotomy for bilateral decompression. And so so what it does is you can have one dilator, which is an endoscope, and you have a camera on it, and you can rotate it, and also so it enters through one side through one of the muscles, and you can rotate the table, and you can use angles of rotating that dilator to access both ipsilateral and contralateral facet joints and contralateral lamina. With the minimally invasive tubular dilators, can we go to the next slide? I think maybe we have them there. The next slide, maybe. Yeah, so there. So the minimally invasive tubular dilators are on the left side. So then you can have two dilators depending on whether you're doing unilateral or bilateral laminotomy, and they appear just like two tubes that are, they start from a small tube and then you enter a larger tube, etc. And that provides the accessing channel to the lamina. So what the study did, the aim of the study essentially was to compare, thank you very much, was to compare these two minimally invasive approaches to laminotomy and to compare their clinical outcomes and complication rates, as well as some surgical outcomes. The clinical outcomes that were assessed were evaluated with post-vestibular disability index. The most common clinical presentation for these patients is pain, whether low back or leg pain. So post-vestibular disability index is one way that to track disability due to low back pain or leg pain. It's scaled from 0 to 100%, with patients who are 80 to 100 are bedbound. The common patients that we would have in this cohort are between 20 to 40% or 40 to 60%. So patients who are 40 to 60% have activities of daily life affected due to pain, and patients to 20 to 40% can still perform activities of daily life. However, their normal other activities such as work and social life are affected because of pain. Visual analog scale, we all know that's from what is your pain from 0 to 10, with 10 being the worst pain and 0 being no pain. So something nice in the methods of this study was that the researchers established a minimally clinically important difference, which is, you can see on the screen, MCID. And so for the VAS, clinically important difference would be an improvement of 3 points. And for the Vestry scale, it would be an improvement of 12 points, rather than, would be a reduction rather of 12 points. Surgical outcomes that were recorded were estimated blood loss, operative time, and hospital stay, as well as post-operative complications. Something I didn't mention, so you can you please keep, thank you. So something I didn't mention is the actual method of the study. So this was a retrospective analysis of a prospectively collected registry type data. So essentially they used clinic data or hospital data to pull all consecutive patients within a certain date range and who met these two criteria, essentially who patients who underwent these two procedures. And so exclusion criteria were dynamic instability, so more serious scoliosis, lumbar scoliosis greater than 20%. Next slide, please. Next slide. The following slide, please.
No, I'm trying. Sorry, it wasn't reacting.
No, that's fine. Okay, so these are the patient characteristics. 40% of patients were females, and that was approximately the same distribution. That was the same distribution between the two groups. I think the table that we're looking at is kind of interesting and important because we want to make sure that the patients between the two groups are equivalent in characteristics. The reason for this is because there was a bias in selecting patients, there was a bias in selecting whether patients would undergo one minimally invasive procedure versus another minimally invasive procedure. So patients who underwent the tubular dilator approach versus the endoscopic approach were selected based on equipment availability. If they had one or two segments of laminotomy that was supposed to be done. However, patients who had 3 or more segments underwent the tubular approach. So that was a little bit of a bias. The reason why I'm mentioning this is because patients' characteristics end up being not significantly different. So they're end up being the same, essentially, between the 2 groups. Average age of patients was 62 years, and 69% had medical comorbidities, which is also important because if we're looking at an outcome of complication rates, that is obviously confounded by medical comorbidities. The starting preoperative Fessler disability index was just about 50, which is kind of significant because this means that these patients had disabling pain that was affecting their activities of daily life. And visual acuity, visual analog scale for low back pain and for leg pain was just about the same, which is about 6.5, between 6.2 and 6.5. I think that's also significant. Next slide, please. So the functional outcomes are noted in this table. As we can see, there is only a difference, a statistically significant difference between the 2 groups at the long-term outcome measure. So outcomes were measured, so VAS and Fessler disability scale was measured at 2 weeks, 3 months, and 12 months. And in the short term, there was no difference between the endoscopic approach versus a tubular approach. Endoscopic approach is the unilateral, tubular could be uni or bilateral, depending on the decompression that needs to be done. However, the 12-month score, there was a difference in the 12-month score, both for pain as well as disability due to pain. Patients who underwent the endoscopic approach had a lower disability due to pain, as well as lower pain reported, both low back pain as well as leg pain. Can we go to the next slide, please? Now, these are the surgical outcomes. And what was interesting to me was that operating time was greater actually in the endoscopic group versus the tubular group. And one of the explanations for this is potentially because the endoscopic approach is not a very commonly used at this point approach, and there's a higher learning curve. And I believe that's one of the reasons why it potentially might take significantly longer time. At least that's something they mentioned in the paper. On the other hand, estimated blood loss was less in the endoscopic approach. And also in the endoscopic approach, patients ended up staying less than a day in the hospital. So their hospital stay was also significantly less. Acute complications, there was no increased morbidity or mortality due to either of these 2 approaches or either of these two methods. However, we have epidural hematoma. A couple of patients had that in the minimally invasive group, but not in the endoscopic group. Durotomy was required to be performed in 2 patients, also in the MIS group, and some paresthesia and urinary retention, which also, these were temporary complications that resolved with time. Can we go to the next slide? All right, so conclusions and limitations. So what was interesting in this study is that the endoscopic unilateral laminotomy for bilateral decompression is equivalent, I would say, is effective, a minimally invasive approach managing lumbar spinal stenosis. It appears to have equivalent outcomes, if not even better outcomes, to the established minimally invasive tubular approach. And while its time was greater, estimated blood loss and hospital stay, which are the patient operative time, was greater for the endoscopic approach. Estimated blood loss and hospital stay, these are the patients, these are more patient-related surgical outcomes, were actually better in the endoscopic approach. So I think as a discussion also, it's important to consider the method of the study. The study so all of the procedures were performed by one physician, by one surgeon. So that is definitely a confounding factor. And it's difficult to extrapolate to other surgeons. One operator, it could be an advantage, obviously, because it controls for the variability of the operator in this particular method. However, it is a disadvantage because we cannot extrapolate these results and make a conclusion whether these outcomes will be similar among other operators. And also, as I explained, the way they assigned whether patients were going to undergo the tubular versus the endoscopic approach was not really randomized, and it was not really systematic. It was based on equipment availability, except in patients who underwent 3-segment approach. And something I did not notice in the paper was them stratifying patients based on spinal segments that were performed. So potentially the results could be skewed because of this. Does that make sense?
Very nice analysis, Elena.
Thank you.
So I have to be careful here because Chris is a friend of mine. So I can't be too critical. But I have to say there are some fatal flaws to this analysis. And the biggest problem is that only one patient in the endoscopic group had a decompression of 3 levels, whereas a bunch more had it with the tubular technique. Now, if you look at the time per level, it becomes very obvious why that's the case. It takes almost 3 hours per level. So a 3-level decompression using the endoscopic technique took 8 hours. Can you imagine an 8-hour decompression for stenosis? That's like doing 2-level vertebrectomies and reconstructions. So you really, I mean, and the problem with that is that also affects the clinical outcome, because 3-level decompressions just don't do as well as 1-level decompressions. You know, they've got multi-level degenerative disease. Even if you decompress them, they still have a lot of pain postoperatively. They just don't do as well as the patient that has a single level decompression. You fix that, the rest of their spine is fine, and they go out their merry ways and do great. So the clinical, not only the time, but the clinical outcomes are dramatically affected by patient selection in this particular publication.
Correct. Yeah, I believe that that the author explains actually the selection, and they explain that they did choose the tubular approach for patients with 3 segments. And so a recommendation of a new analysis potentially could exclude patients with 3-segment laminotomies and only compare to 1 and 2, and then that analysis might be a bit better.
Now, I'm not certain, but you suggested that in this paper, to do the tubular technique, they dropped 2 tubes, 1 on each side. That's not the way you do these. When you're doing a tubular decompression of stenosis, you only drop the tube on one side. And then when you're done doing your decompression, you simply angle it and you drill out the ventral portion of the lamina to the contralateral pedicle and remove the ligament. So you do a bilateral decompression, but only through a unilateral approach.
I'll be honest, I was not fully clear on this because I have seen decompressions with the 2 tubes on the sides. And the way I understood this paper was that the tubular approach was using that, whereas the endoscopic approach was using the one with the angling of the table to access the
Well,
contralateral.
you do the same thing with the tube. You just angle it and do both sides. And it's really, I mean, it's a 45-minute outpatient procedure. So it's pretty slick. Now, that being said, you know, I think our major limitation on the percutaneous endoscopic technique right now is the size of the instruments we can use. They're quite limited, and that's why it takes so long. If we can get to the point where we can get bigger instruments that actually get the job done faster, it might become a very viable technique.
Sure. I suppose it's up to us to kind of advance this.
Yeah, now, you know, we old guys are done. It's all up to you guys now.
When you say bigger instrumentation, are the instrument, I haven't seen any endoscopic, unfortunately. It was the pandemic or my research year. Is it the same as the robotic instrumentation for the lumbar spine, that size wise?
Yeah, for example, if you're going to do, you're doing a discectomy or you're doing a decompression, the biggest pituitary rongeur you're going to be able to use is about 2 millimeters.
Gotcha.
Same with the Kerrison punch. So there's no way you can stick down a 5 millimeter Kerrison and take a big bite of that lamina. You know, you're going to stick down your 2 millimeter 5 or 10 times in order to get the same effect that you can get with one bite using a tubular approach. And that's why they take so long.
Yeah, that makes sense.
Makes sense.
But it's important, I think, you know, if we hadn't pushed the edge on minimally invasive surgery 25 years ago, we wouldn't be doing the type of surgery we're doing today. So it's time to push the edge on the endoscopic surgery.
Yes, and there's I didn't see the other presentations, but to this point, there are so many other newer approaches, not through the back, that are also quote unquote minimally invasive, like the O-lift and the A-lift and the X-lift and all of these. So they don't disrupt the back musculature, which is essentially keeping the spinal column together. Right?
Exactly. Yep. Yep. All of those are fabulous techniques.
Awesome. Do we have any questions from the audience?
Yes, we have one from Isabella.
Oh, okay. So this actually goes back to talking about Dr. Fessler's earlier research. So with regard to dopamine inhibiting prolactin, do you think that might have implications for postpartum depression?
It probably does. Absolutely.
Awesome. Any other questions?
I actually had a question regarding, because I saw that they use the MCID approach, the minimum clinically different differences, to assess their outcomes. What are your feelings on doing the raw delta change versus seeing if the delta meets the MCID? Because I think based on the MCID for this study, the results of the last study may be a little bit more like it would be impacted. What are your feelings on doing analysis that way?
You know, it's interesting. They give us different data, don't they?
Mm-hmm.
The raw data tells us how much they actually improved in their pain, for example. The MCID gives us the subjective patient impression of how well they're doing. Both of those are affected by lots of other things. If they have hip pain, if they have knee pain, if they have just degenerative changes at multiple levels, they're all affected by that. But you know, one of the things we've learned is that the objective change is not necessarily correlated with the patient's perception of their improvement. And you know, I've actually done a lot of analysis of this kind of data, looking at patient preoperative expectations versus their perception of outcome compared to their actual outcome that they receive in terms of our standard measures. And very often they are not correlated. You know, you have to take into account the patient's level of depression, what's going on at home, if they've had a recent death in the family, if they're taking care of sick family members. All of those things impact MCID more than the VAS or the Westry Disability Scale, for example. So you have to be very careful in how you interpret these, but it's always good to look at them at the same time, compare them together. And another thing to look at is the surgeon's perception of their outcome versus the patient's perception of their outcome, because those often differ as well.
Thank you.
You know, one of the
Okay,
things
well-
I've noticed, for example, is that a patient will come in and all of my patients fill out just a ton of questionnaires preoperatively and at every visit postoperatively. But then you get the very simple things of when they talk to my nurse or my nurse practitioner, what they say to them, and then what they say to me when I go into the room. And it's very often that they will complain about everything to my nurse or nurse practitioner. And when I walk into the room and I say, "How are you doing?" they say, "I'm doing great." You know, so it's very interesting. Most patients like their surgeons, they trust their surgeons. They want their surgeon to feel that they're doing well, even if they're not. And so they'll complain to the nurse, but they'll tell me they're doing great.
Do you think the patients would, do you think the outcome scores would be different if surgeons were interviewing the patients themselves and getting the raw score that way? Do you think that's an influential factor based on who's interviewing the patient for these outcomes?
I think it is, but all our patients do this on an iPad. So there's nobody interviewing them.
I see.
Just to piggyback to that question, so when you say they're doing it on an iPad, are they doing it in the office or are they doing it at home? Because I feel that there might be a difference.
You might be right. And the patients have the option of doing either right now. Particularly during COVID, a lot of patients didn't want to come into the hospital. So most of them were filling it out at home. And then we would do telephone or Zoom interviews. Most of the time, though, if they're coming into the office, most patients want to do it in the office.
Interesting. Yeah, because when we were at Rothman, we did a lot of these. The call center actually calls the patients for a lot of these, and then or they have the option to do it on the tablet, but they never record like which way they actually acquired the information, whether it be on a tablet via the call center or on paper, and someone entered it in when they were at the clinic.
Yeah, and we don't either. You're absolutely right on that.
Interesting.
Very interesting methodological study to be done there. Assess those differences.
I'm interested in the psychological outcomes of patients. I went to Rothman to do outcomes research because I thought it was interesting.
Awesome. Well, we're just getting to the 9 o'clock hour, and actually the group that was supposed to present the first paper was not able to due to clinical responsibilities. So I came up with a few slides for it if we want to go through those, but I know it's past the hour mark, so we can definitely cut the conversation there. I think it was a great discussion of these two papers. I don't know how people are feeling. Dr. Fessler, if you have
Up to you guys.
I'm open to listening to what you put together. You put the effort and time to put it together. So.
All right, let me, I'll try to do the watered down quick version here. Just to skip through some of the background and stuff. Okay, so this was a clinical trial out of Sweden, and this was their 5-year outcomes data on artificial disc replacement versus ACDF in patients with cervical degenerative disc disease and concomitant radiculopathy. So I can skip through this here. I'll skip through this basic stuff, although I thought this was like a really nice image from orthobullets for anybody that struggles with the motions at different joints. Nice way to visualize it. Okay, so again, this study was looking at comparing the gold standard treatment of cervical degenerative disc disease, which is anterior cervical decompression and fusion. And the way that this is done is going to be a discectomy to remove the compressive disc. A bone graft is then going to be placed in the area of the disc, and then it's going to be plated. And this is to facilitate fusion between the two vertebrae. And of course, the limitation with ACDF is going to be the reduced mobility that is encountered postoperatively. More recently, there's been work looking at cervical artificial disc replacement, especially in the context of disc herniation. And of course, this would involve removal of the herniated disc and then implantation of a artificial disc into the disc space. And the goal here is preserving the disc space in an effort to relieve compression on the nerve root and counter the radiculopathy that results. The advantage here is going to be the preserved mobility, as well as the thought that it will prevent any development of adjacent spine pathology. So this is the flow chart for patients that were included in the trial. So inclusion criteria were 25 to 60-year-olds with cervical radiculopathy owing to pathology at 1 or 2 cervical levels. The patients had to be eligible for both ARD, ADR, or the ACDF. And of course, because it was conducted in Sweden, they had to be able to understand the Swedish literature that was provided to them. A number of exclusion criteria: previous cervical spine surgery, greater than 2 cervical levels. So this was limited to 1 or 2 levels. Any types of systemic disease that would impact compliance, history of cervical trauma, and then known allergy to either the implant material or to NSAIDs, kind of showing how important the NSAIDs would be in the postoperative management. So for the patients, there were 287 that were assessed for eligibility, and a total of 134 were excluded. This left 83 that were randomized to the ADR intervention versus 70 that were randomized to the ACDF intervention. And I thought it was pretty interesting. So this was a blinded closed envelope technique trial. So the surgeon would open via an anterior exposure via the standard approach described by Smith and Robinson. And it wasn't until they had the exposure that they would then be handed the envelope that would dictate what arm of the trial that the patient was actually allocated into. And I think that's just interesting, you know, in thinking about how surgical clinical trials are conducted versus pharmaceutical, and how, you know, keeping the blinded approach here. So ultimately, there were a couple of follow-ups that were published. So the 2-year data as well as 5-year predictive data were published. And now this is the 5-year outcome analysis. For the ADR, there were 83 patients that were analyzed via intention to treat analysis, compared to 67 that were analyzed via the per protocol analysis. And then for the ACDF arm, there were 70 for each analysis. So all patients were eligible for each analysis in the ACDF. Outcomes assessed. So the primary was the Neck Disability Index questionnaire, and just included here on the right for anybody that's interested in seeing the components of it. It includes pain intensity, various activities, ability to read comfortably, driving, sleeping, things like that. The secondary analysis, as we've seen in some of the other papers, focused on the Euroqual 5D, which focuses on these 5 dimensions of overall health. The visual analog scales for neck and arm pain, being that this is cervical, focusing on the upper extremities. They looked at dysphagia as a possible postoperative complication related to the anterior approach. And then also the hospital anxiety and depression scale. As for tertiary outcomes, independent neurological exams were performed at 5 years post-op, and then there was imaging performed along with that, looking at flexion extension, defining motion as greater than 5 degrees of flexibility at a given joint. So a 5-degree difference between the flexion and extension films. And then there was also MR imaging used to assess for facet arthropathy and disc degeneration in the adjacent segment. So a way to assess that adjacent segment pathology that is thought to be prevented by ADR. So for the primary outcomes, they noted no difference at 5 years between the ADR and the fusion groups on both the neck disability index and the EQ-5D. And they did, again, the comparison in both an intention to treat and a per protocol analysis. And the results were fairly similar. So there was really no difference in the method that was used in analysis on the results. However, there was one result that did become significant in the per protocol analysis, and that was dysphagia. So there was a slight protective effect of ADR on dysphagia compared to the ACDF. Interestingly, when they did a stratified analysis for sex, looking at females and males, they noted that there was a significantly higher rate of reoperation in women that were operated via ADR compared to fusion, and this effect was not seen in males. And one of the thoughts that they have as to why there might be more reoperations is that a lesser vertebral bone density and size in women might facilitate this loosening and subsidence problem. And that's borne out in the results here, showing that that was the primary cause of reoperation in women in this cohort. They also looked at the prevalence of facet arthropathy via the 5-level grading system. And the way to sort of interpret this table shown here, the rows are going to be the preoperative groups. So somebody in the 0 group here would have had a preoperative facet arthropathy grade of 0. And then the columns here are going to be the postoperative grading. So for example, this group here began with a grade of 0 and at the 5-year analysis had a grade of 0. And then down to the bottom, for example, somebody in the row in the cell here would have began with grade 3 and completed with a grade 3. And essentially what they were looking for was a trend towards moving from a lower grade to a higher grade, and that is what they saw in the ADR group. So the grades appeared to increase by about 0.5 within 5 years in the ADR group. So just summarizing those results, so for the primary outcome, patients in both the ACDF and the ADR groups had their NDIs halved approximately by 5 years, and there was no significant difference in those in the NDIs. As far as the secondary and tertiary outcomes, there was a modestly lower risk of dysphagia in the ADR group by the per protocol analysis. This was not significant on the intention to treat analysis. There was a higher risk of reoperation in women in the ADR group compared to men. So there was some evidence of a gender disparity here. 54% of the ADR patients had preserved mobility of at 5 years, and this is the benefit that is attributed to ADR, is that it is supposed to be a mobility preserving approach compared to fusion, which of course is going to attenuate the mobility at that joint. However, 25% of these patients had a spontaneous fusion in the ADR group, and there was a significantly higher risk in men in this ADR group. There was progression, as we saw, of the facet arthropathy by 0.5 grading at 5 years after the insertion of ADR. And most notably, ADR did not deter the development of adjacent segment pathology, and that's been one of the kind of benefits touted by ADR, is that it's thought to, via preserving mobility, prevent the development of the adjacent segment pathology, but that was not borne out in this study. So assessing and critically appraising the study, there were a few strengths. So MR images were included regardless of whether the symptoms were present or not in the 5-year follow-up. So every patient had follow-up imaging that was included in the follow-up analysis. The follow-up rate after 5 years for the primary outcome was 88%. They utilized both ITT and PP, so intention to treat and per protocol imputations to account for any of the missing data that they had here. And then they also used blinded randomization via that closed envelope technique until completion of the decompression phase. So this allowed for both blinding of the patient and of the surgeon as to what group the patient was going to be randomized into. There were some notable limitations. So this study used a unconstrained ADR device, and it therefore might not be generalizable to the constrained ADR devices that have been developed. And despite the fact that patients had MR imaging regardless of symptoms, there were limited MR images that were available at follow-up. And there was also a lack of uniformity among the MRI machines used. So there might have been some disparity in the quality of the images. So just some general conclusions here. So ultimately in the primary outcome, there were no significant differences. And in most of the primary secondary outcomes, there were no difference between the ADR and the ACDF groups at 5-year follow-up. The exception to that was the dysphagia score, which again was somewhat protective in the ADR group. Although mobility was preserved in greater than 50% of the ADR group, we saw that this was not sufficient to protect against adjacent segment pathology. So it requires sort of a reevaluation of that as a benefit to be considered of ADR. And then finally, there was sex disparity related to reoperation in the ADR group due to either loosening of the device or subsidence. And again, this was thought to be related to sexual dimorphic anatomic differences, being that women have smaller, less dense vertebral bodies compared to men. All right, so let me stop sharing here, and happy to take any questions. And Dr. Fessler, I'm curious to hear your thoughts on the study.
This is a very interesting study in that the results are very different than multiple studies that have come out of the United States. And I think there are several reasons for that. One of them is how exactly you ask the question. So an artificial disc isn't supposed to prevent adjacent segment pathology. It's intended to allow the degeneration to proceed without acceleration. So as we age, our joints are going to age with us. And so we would expect there to be the progression of adjacent segment degeneration. The difference comes in whether that adjacent segment degeneration is accelerated or not, and if it requires reoperation. In the studies published in the United States, starting at 7 years and by 10 years, there is a significant difference in the number of patients that need to be reoperated, and the artificial disc group is experiencing a less reoperative rate. I've been doing artificial discs now for at least 15 years, and that is certainly my experience, that the patients getting artificial discs have a significantly less rate of reoperation than my patients who I've done fusions on. The other thing that's a little misleading is talking about the adjacent segment facet arthropathy. If you give a patient an artificial disc, they are going to develop adjacent segment arthropathy. That's what happens as we age. If you fuse them, the facets fuse. So of course you don't get adjacent segment arthropathy because the joints are fused. So that's not a fair comparison. And I've always had difficulties with imputation of data. it's sort of saying, well, this is what we think the data would have said, and that's what we're going to use in analyzing it. I've always been uncomfortable with that.
Mm. Yeah, that definitely makes sense.
That being
Yeah, and
said,
it looks,
I think it was a good study.
yeah, and it looks, as you mentioned, as we start to get out to the, the 6 and 7 year time point, that's where they really start seeing this difference in the males and females in their version of a Kaplan-Meier here on the occurrence of events, which is interesting.
So at 25 years old, or 30 or 35, however old you guys are, what do you want? Do you want a fusion or do you want an artificial disc?
Artificial disc.
Yeah,
Yeah.
that loss of mobility would be devastating, I think.
I've had family members had a fusion, and it definitely does decrease the mobility, and I feel like they have to just be more gentle or careful, and I'm a very active person. And then when they aren't, I've seen them go from 2 segments to 3 segments to 4 segments to 5. It just goes up, and
Yeah.
having revision rates. And my best friend's grandmother had proximal junctional kyphosis, and she ended up she didn't get to enjoy like her great grandkids' 2nd birthday, and she was just miserable and in pain. And it all started off with one lumbar fusion. So
Yeah.
a little biased there. So what about everyone else?
Yeah, I think I would also go with the disc. I think it depends how old you are, probably in my case, and how active you are, right? Some people are not very active and they're just happy to be out of pain and not be in pain, and that works for them.
Yeah, someone noted in the chat, fusion begets fusion. Dr. Fessler, looking at the occurrence of dysphagia, which they saw was slightly less in the ADR group, what do you think might underlie that compared to fusion?
I think there are 2 things that influence that. One is the number of levels you're fusing. So if you're doing, for example, a 4-level fusion, the incidence of dysphagia, at least temporarily, is relatively high in that group. So there may have been an influence on the number of levels operated on in fusion versus the artificial discs. Beyond that, and the other thing is that with the artificial discs, swallowing isn't just swallowing. It's an entire coordinated motion of your head and your neck and your upper body. So when you have an artificial disc, that motion stays the same. And you tilt your head a little bit, you move your head a little bit forward, you open up your esophagus so that you get a clear passage of food down your esophagus. When you have a multi-level fusion, you can't do that as well. Certainly when we used to do occipital cervical fusions, we learned that lesson very quickly, because then the patients couldn't tilt their head, they couldn't shift back and forth. They had a lot of difficulty swallowing. It had nothing to do with any anterior surgery. It was the fact that swallowing is a very complex motion of our head, our neck, and our upper body. When we take that away with a fusion, it's going to affect your ability, your food's going to get caught.
Is that something that, in your experience, compared to like a nerve damage, is that sort of physical loss of function something that can be corrected with like speech language pathology or some kind of rehab?
Not very well, not very well. And that's why I personally will not do a 4-level anterior fusion in an elderly person, because they've got a 50% chance of having difficulty swallowing permanently. And that's really a life disabling problem. 3 levels, there's not such a big problem. 4 levels, there is. So if I have to do 4 levels, I will do it posteriorly. I won't do those anteriorly anymore.
So you find the multi-level posterior better with the swallowing, even though there's restriction in mobility?
Yes. Yep.
Would that be because of manipulation of the nerves around?
Well, I think it's manipulation of the esophagus. I think it's the length of time and the length of esophagus that you have to retract.
Does that dysphagia get better over time ever, or?
Most of it does. There's about a 7% incidence of permanency.
Interesting.
So that's closing in on 1 in 10.
That's very interesting. Thank you.
Yeah,
It's been
thank
my
you.
pleasure. It's been great meeting with you guys.
Yes, you too. Thank you so much for joining us and taking time out of your Tuesday evening after clinic.
Happy to do so. I'm going to step out now. You all have a good evening.
Thank you for the
Yes, you too.
discussion.
Thank you.
Thank you, sir.
Thank you so
Bye.
much.
Thanks for the opportunity. It's been fun.
Right. For any of the other attendees, again, definitely register for the Race for Neurosurgery Education and feel free to volunteer for future sessions.
Will do. Have a nice
All right.
evening.
Take care.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.